Good morning, everybody. If we could get seated, and it's really an honor on behalf of the APA to present Dr. Vijay Singh as this year's distinguished lecturer for the Paul Webster lectureship, which is one of the two keynote lectureships for the AGA. As you know, Dr. Webster, an esteemed authority in pancreatology, is one of the co-founders of the APA. Dr. Vijay Singh received his MBBS from Punjab University and then did his internship at Christian Medical University, and then did his postdoctoral research fellowship at Beth Israel Deaconess Medical Center, followed by residency and GI fellowship at Mayo Clinic, and after early faculty at the University of Pittsburgh, he's now professor of medicine at Mayo Clinic in Scottsdale, as well as consultant in the Department of Medicine and Department of Biochemistry and Molecular Biology. And I'll try to give a brief synopsis about his research, and you'll hear much more about it momentarily. He's interested in the function of pancreatic aster cell using sophisticated molecular and cell biology approaches, and looking at vesicular trafficking, cytoskeletal regulation, and intracellular signal transduction. And in particular, he's interested in obesity-related pancreatic, how obesity-related pancreatic fat worsens local injury via unsaturated fatty acids. His team is developing a technique known as transgastric local pancreatic hypothermia as a new multimodal therapy for acute pancreatitis. So please join me in welcoming Dr. Singh.
Well, thank you for the very kind introduction. It is really an honor to be presenting the Paul Webster lecture to this august audience. I first came to the APA 23 years ago with Dr. Ashok Saluja. I had just joined the lab and he said, come along, I'll show you what it is like the APA. And I must say that was an excellent start, getting introduced to the APA and learning about the pancreas. And over the last several years, the nurturing that the members of the APA, the icons, have provided has been instrumental in my learning. And what you'll see next would not have been possible without that input. This is my disclosure, and it's been the same for the last 10 years. Not much has changed, and you'll see why. As I describe what I learned, I'll go through the stages of how I learned those. So there were various stages. In 1998, I started as a postdoc in Boston, after which I did my internal medicine residency and fellowship at Mayo Clinic, Rochester. My first faculty appointment was at the University of Pittsburgh in 2009. And then in 2013, I moved to Scottsdale. And each of these provided a unique environment for me to learn. So 1998, Boston postdoc, my first appointment here with Dr. Ashok Saluja and Michael Steer at the Beth Israel Deaconess Medical Center. These are views from the lab, the 8th floor of the Dana building. I must say those were beautiful times. The views were inspiring. You could see the Prudential and the Hancock, the nice skyline of Boston. And there was always a reason to stay late and work long. There were no complaints there. Yeah, loved it. And yes, it was trypsin time. What I learned in those formative years was that the pancreatic acinar cell normally is a polarized cell, has granules, it secretes everything apically normally, doesn't have intracellular trypsin, and when there's an insult that causes pancreatitis, there is trypsin generation in the cell and an inhibition of secretion from the apical surface. There's basolateral leakage, which you can see here, those granules leaking on the basolateral surface, and that is crucial to the pathogenesis of pancreatitis. So the goal was, can we change the course of pancreatitis by inhibiting this phenomenon? And indeed, it was very successful. Inhibiting trypsinogen activation and preventing trypsin generation was very effective in animal models of pancreatitis. Whether it was PI3 kinases that we inhibited to prevent trypsinogen activation, or upregulation of heat shock proteins, or it was cathepsin B inhibition. All approaches worked. It was very exciting and very encouraging. One of the things that I was curious about was, could the same phenomenon of inhibiting trypsin also reverse the inhibition of secretion? And we were very excited. In fact, this was one of our first projects. But it was a peculiar finding. Whenever we used protease inhibitors, we found, whether it was TPCK, TLCK, BSF, we inhibited secretion. We did not reverse the inhibition, rather we made the secretion to get more inhibited. That was very puzzling. And we had to call in the gurus in this, who are the experts in cell biology, and they are here in the audience, Dr. Williams and Fred Gorlick. And we scratched our heads and tried various things, and then we decided, well, maybe it is the apical cytoskeleton. And indeed, it seemed that under normal circumstances, the acini has microvilli on the surface with apical actin. On fluorescence, you can see this rich apical actin, and there's this basolateral, very little actin. But when we give trypsin inhibitors, the whole phenomenon seemed to change. There was loss of apical actin, the microvilli were lost, and the actin moved to the basal surfaces. Well, this was a learning lesson that maybe inhibiting trypsin does not do all, but the other papers seemed great. So maybe trypsin inhibition was the way to go. And with that exciting message, I went to Rochester. Maybe there is a clinical relevance of inhibiting trypsin. In Rochester, I met the gurus in clinical pancreatology, Dr. Suresh Chari, Santi Vege, and I'd often have discussions with them about, how about let's try this, inhibiting trypsin and seeing a change in clinical outcomes. And I learned that there had been many studies done in the past, perhaps, and maybe we should do a meta-analysis on that. And we looked at, indeed, I did a lit search. This is from 2004, one of my old presentations. And there were about 70 articles on various trypsin inhibitors in pancreatitis, clinical trials that had been tried, whether it was gabaxate, whether it was a protonin or FOI. And when I read through those papers, it wasn't seeming too exciting. But while we were trying to do the meta-analysis, a meta-analysis came out. So we were beat to it. The meta-analysis claimed that there was no big difference that the protease inhibitors did, but they did say that maybe in moderate to severe pancreatitis, there was a benefit. We reviewed it carefully. I believe that was one of the most thorough lit searches I did with Dr. Chari. And at the end of it, our comment was that the conclusions of the meta-analysis were suspect, that there was a reduction in moderate to severe pancreatitis. So this was a commentary that we sent to Gastro, and our thought was that there was a lot to be learned from failed clinical trials in protease inhibitors, and that's where we closed. So that was not very exciting. That something that I had been excited about in trypsin inhibition and all, and we didn't see it pan out here. What else could be done? So could we repurpose drugs? At that time, one of the main things that I was learning was HIV was associated with an increased risk of pancreatitis. And if we split the time period into two phases, the pre-HAART era and the post-HAART era, HAART meaning highly active antiretroviral therapy, which was introduced in 1996. Prior to HAART, most of the therapy of HIV was monotherapy with reverse transcriptase inhibitors. And what was happening was they would see very high incidence of pancreatitis over here. But when the aspartyl protease inhibitors like nelfenavir were introduced, there was a big reduction in pancreatitis. That was exciting. And yes, we did find nelfenavir to reduce the severity of cerulean pancreatitis. We presumed it was via inhibition of the permeability transition pore. So that seemed nice, that perhaps we could repurpose some drugs like that. At the same time, the inhibition of secretion, reorganization of actin always was at the back of my mind. And I was lucky to join the lab of Dr. Mark McNiven. And what you see here is an acinus. The green is the green fluorescent protein actin. And the red are the chymotrypsin labeled by DS-Red. And what you can see is in this acinus, which is stimulated with high dose cerulean, there is this basolateral leakage that you just saw. that takes place from these huge blebs that form on the basolateral surface. And perhaps this could explain the increase in blood amylase lipase that we see, and perhaps, as you'll see later, maybe the fat necrosis that we see. So this was exciting. And with the potential of repurposing drugs, I was excited, and I went on to, though I did realize that targeting proteases may not be effective in pancreatitis. With that excitement of repurposing drugs, I went to Pitt. At Pitt, it was my first faculty appointment. I was very excited. And I asked the pathologist, I said, can we look at, please, what human pancreatitis looks like? I wanted to know what is the cell death in human pancreatitis. My experience had all been in mouse models to look at apoptosis and necrosis. And the pathologist said, we don't get pancreatic tissue much from pancreatitis patients. So, well, all we could find was an autopsy database. And there was all this question about autolysis and postmortem change. And I said, well, let's still take a look. And when they pulled up the pictures, whenever we would look at the histology of pancreatitis, she would show me this bluish mass of dead adipocytes and surrounding damage of pancreas. And I would say, what is this? She'd say, well, this is fat necrosis. That's what we see in pancreatitis. And I said, this is postmortem change. I don't think. Incidentally, those disagreements became big, and it led to some marital discord simply because the pathologist was my wife. There was a period of silence. We would be sitting at dinner table and it would be quiet for a while. But I did have friends, George and Dheeraj and David, and we would meet in the hallways, and I would always get a chance to talk a little bit about what we were finding and if it could explain what severe pancreatitis was. And what I would learn from then is that obesity seemed to be a risk factor for severe pancreatitis. And it did seem correct, because whenever the CTs were reviewed, we'd see this huge necrotic mass in the pancreas. And after some time, it occurred to me, could it be that what we were seeing histologically here and in that necrotic mass was essentially the same phenomenon? And if so, how would we ever prove it in this big mess of necrotic pancreas, that it was fat necrosis that was resulting in it? After a lot of thinking, we came up with a plan, perhaps, that we should make a system in which we can co-culture adipocytes and acinar cells to see how one influences the other. And we developed this co-culture system, acini on the top, adipocytes at the bottom, cultured them. And we measured various endpoints of cell death, inflammation, and lipolytic flux between the two compartments. It did seem to work. We needed to prove that this is lipolysis, so we had to put a lipase inhibitor such as orlistat over here, and it did seem to work. So what we saw was that when we co-cultured them together, the acinar adipocyte condition induced a lot of fatty acid increase in the acinar compartment. And when we put orlistat, that fatty acid increase was prevented. At the same time, we would note a lot of cell death. This is propedium iodide staining at that time, occurring in this co-culture system, which was completely prevented by orlistat. Was interesting, but this was all new areas for me, lipases, orlistat. I didn't know much about lipase. I knew about trypsin, but not much about lipase. And it was with that I consulted. I was lucky to have Dr. Mark Lowe at the Pittsburgh Children's Hospital. And I remember that afternoon when I took all my data to Dr. Lowe. It was 76 slides in a PowerPoint, and spent 2 hours with him, showing him all the data. And I said, what do we do with it? He said, well, write a grant. I said, I asked him, will you be my mentor? He said, no, you don't need a mentor. You have all the controls here. Write your own grant. That was too bold a move for me, but I did. And I was lucky. The first grant got funded. And at the same time, it was with a lot of collaboration and help with my colleagues at Pitt, Dheeraj, George, Adam, Kenley, that we got various necrotic samples from, whether it was endoscopic or percutaneous or surgical debridements from these necrosis samples, that we measured fatty acids in. And we did find that there was a lot of fatty acid in this necrotic mess, very similar to the amounts which we saw in the co-culture system. And yes, that based on this, when we put the picture together, when we inhibited lipases, we found a big reduction in animal model severity only in the obese mice, not in the lean mice. This was the paradigm that we published then, that perhaps in the obese patient, when there was an insult and the acinar cell was damaged, there was a local lipase leakage, but in that obese fatty pancreas, adipocytes were damaged that leaked out unsaturated fatty acids, which damaged the acinar cells more, and that perpetuated the injury to severe pancreatitis. This was published about 10 years ago, exactly actually to this week that we published this. So with that exciting news that it was perhaps all to do with the lipolysis in fat, I moved to Scottsdale in 2013. However, one nagging question remained, that is it the fatty acids or is it the cytokines? Because there was a very big cytokine response we were also noting, and more so in the same necrotic collections in which we found a lot of fatty acids, oleic acid being the most dominant, closely followed by linoleic acid, 18.1 and 18.2 respectively. We also found a lot of cytokines. For example, we found a lot of IL-1 beta and IL-8, the rat equivalent of which is Cro-alpha, as you will see. So how do we prove one leads to the next, or if it is parallel or consequential? Well, we took the triglyceride of oleic acid called triolein in this red line over here and gave it to rats, lean rats, and induced a mild model of pancreatitis called the cerulean model, CER. And what we saw was that rats that had been given the triolein did have a bad outcome. In a mild model, it became severe. Survival went down. There was a lot of lipolysis in the triolein given group, and there was a lot of oleic acid generation, which was prevented by orlistat when given along with the triolein. But IL-1 beta and KC-GRO did nothing. In fact, the triolein group had a much larger increase in the same cytokines that we gave to the rats. The rats did have a response to the cytokines. It's not that the cytokines didn't work. They were hot. The rat temperatures had gone from normal of about 37.5 to 39.5. You could touch them and feel the warmth. And we recorded this also. So even though we were inducing an inflammatory response in hyperthermia, we were not inducing pancreatitis outcomes in these rats. And we saw the same thing for organ failure. For example, here, I'm just showing the BUN part, kidney failure went up in the triolein treated rats. And this was published later. So what we learned from this was that perhaps it is the fatty acids that cause the cytokine response. The second thing we learned from this is perhaps initiation does not equal outcomes, that we can take a mild model like cerulean and make it become severe just by a modifier, such as triolein over here. So it's the modifier that changes the course of pancreatitis, not the initiator. And the last thing that we learned, which reinforced my previous thoughts, was that it's the triglyceride lipolysis. It's not obesity, because these were lean rats, but you can make the pancreatitis severe just by the triolein sitting there. So it is the triglyceride lipolysis, not the obesity, that makes things worse. So just to summarize, what we've learned over here is that we can have various etiologies of pancreatitis which initiate it, but the outcomes have nothing to do with the initiation. The outcomes are modulated by the modifier, such as which generates unsaturated fatty acids, which may worsen pancreatitis. There was one more lesson that we learned over here, which I would like to show at this point, and that is a marker is not a mediator. This is we commonly get excited by seeing something go up in a disease model, but that distinction between markers and mediators is hard to make, is hard to characterize. And this slide will just focus on that aspect that I learned. So let's take alcohol, for example, a very common cause of pancreatitis. The diagnosis of alcoholic pancreatitis is based on history. You ask a patient, do you drink more than 50 mils per day for the last 5 years? I wonder whoever gives that history or who remembers that. Nobody keeps the diary. But anyway, that's the classical question we have to ask. And if the patient says yes, then it's alcoholic pancreatitis. That's the ACG guidelines I just recited, 50 mils for 5 years. But one of the metabolites of alcohol are fatty acid ethyl esters. And those were big about a decade and a half ago about how they may be causing pancreatitis to get severe. So we looked for this. One of the papers that is similar to understand the role of fatty acid ethyl esters is the first paper that described them. It was published in Science in 1986. And what they had done in that paper was simply take these are people who had died in motor vehicle accidents. And in the black bars are the people who were acutely intoxicated, not chronic alcoholics. The hashed bars are those who were chronic alcoholics, but did not have pancreatic disease. And the white bars are the ones that were not intoxicated and had no alcohol history. And what they reported over there in that paper was that the highest amount of fatty acid ethyl esters was in the adipose tissue. In the acutely intoxicated, it was in the pancreas, but the highest amount was in the adipose tissue. And we had tried to understand this previously about what is the role of these. So we took the ethyl esters of oleic acid, injected it into the pancreatic duct. We got some necrosis, some damage, from the manipulation, not much more than just the sham. But when we injected the triglyceride of oleic acid, there was severe hemorrhagic necrosis and bad outcomes, similar to the ones I described in the previous slide. Took a lot of time, but eventually we realized that it is perhaps what we are seeing over here is what Laposata described, that it is the release of fatty acid ethyl esters. So when there is pancreatitis and fatty acids are released from the fat necrosis, because fat is all triglyceride normally, and when it's hydrolyzed by lipases into fatty acids, when they're released into circulation, at the same time, there's a parallel release of the ethyl esters that are sitting in the fat, which enter the circulation, and perhaps these could be used as potential biomarkers of alcoholic pancreatitis, and our reliance on an unreliable history of a patient in distress in the ER will have to go down. These studies would not have been possible without my collaborators, Dr. Stacy Well at the VA, Biswajit, Shubham here, Andre, and Dr. Christine Snozek at the Mayo. The next question was, okay, there are so many lipases, and the most popular one is ATGL. So which lipase causes organ failure? The clues to this, we thought, would be best if we compare a disease with fat involvement, but no less organ failure, such as acute diverticulitis. There's pericolonic stranding, as we call it, and there is peripancreatic stranding, which progresses to fat necrosis and pancreatitis. So we took the two samples, two types of diseases, and we measured just on a simple TLC, the nature of the fat over there. So diverticulitis was mostly triglyceride, but in pancreatitis, it had been hydrolyzed to fatty acids. Most of it had been hydrolyzed to fatty acids. And in pancreatitis, there was about 100-fold higher lipase in that pancreatic necrosis collection compared to what we saw in diverticulitis. And most of all, while ATGL, the popular lipase, was present in the diverticulitis fat, it was totally gone from that in pancreatitis. And it was after a lot of collaborations and getting knockout mice for ATGL and generating knockout mice for PTL with our collaborators, Dr. Aaron Kershaw, Mark Lowe, that we eventually published that it is not the adipocyte lipase, but the pancreatic lipase that leaks into the adipose tissue that causes all this fat necrosis. With George, we analyzed more samples that he sent us, and what we saw was that patients with severe pancreatitis had high oleic acid levels in their serums compared to controls. And when we gave the same dose of oleic acid to mice, the same serum levels, we induced the cytokine response, IL-6, TNF-alpha, MCP-1, all went up by 100 to 1,000-fold. And we induced organ failure, the same endpoints relevant to human pancreatitis, with a lot of shock, BUN elevation, and hypothermia taking place in these mice. And that was the basis of what we published last year, that it is pancreatic triglyceride lipase that contributes to the fat necrosis by leaking out of these acinar cells and hydrolyzing the normal triglyceride in these adipocytes, which you see as those E structures, triglyceride being hydrolyzed to these linear chains of red, which are non-esterified fatty acids entering the circulation and causing organ failure. So what we've learned from here, is it clinically relevant? This is all mouse models, some human samples. To understand this further, we said, okay, well, if in the other part that you may have gathered was that we are talking oleic acid, unsaturated fatty acids, and we are taught unsaturated fatty acids are good. What is the proof that this is relevant to clinical outcomes over here? So this is just one summary slide in which we summarize parts that went into a meta-analysis where we found that yes, patients who have severe pancreatitis at less than a BMI 25, and this is based on numerous studies over the last 30 years from various countries. The papers that came from cutoffs less than 25, shown here in the pink box, came from countries, and you can find this on the Food and Agricultural Organization database, countries that had a lower saturated fat consumption per capita and a higher proportion of unsaturated fatty acid intake. Whereas the studies that showed a cutoff above 30 body mass index had a higher proportion of saturated fat intake over this period. And to understand this, when we did animal models and culture experiments, what we found was if we go by what you eat is what you accumulate, if we take saturated fat, the peripancreatic adipose tissue becomes saturated. And that is shown over here in those blue bars inside these adipocytes. Those are the fatty acids that are saturated inside the adipocyte. And that doesn't fit very well into the pancreatic lipase pocket shown over here. However, if we take an unsaturated fat source, such as which have double bonds in them, and they kink the fatty acid where those double bonds are, they are shown in these red V-shaped structures coming off the triglyceride. Then the adipose itself, by consuming unsaturated fat, and our marker has been linoleic acid, which is an essential fatty acid, only comes from diet, the fat also becomes unsaturated. And that fat fits much better into the lipase pocket. The triglyceride fits snugly into the lipase pocket, whereas the saturated triglyceride, the saturated fatty acid pushes it out of the lipase pocket, making the lipolysis of the triglyceride less efficient. Moreover, the double bonds in these fatty acids make them much more aquastable. So not only are they hydrolyzed more, resulting in a lot of these V-shaped structures that you can see at the bottom, but they are also much more aquastable. And that aquastability results in higher unbound fatty acid levels, which eventually results in organ failure. So is that all? Well, that's, if you said pancreatitis, yes, that would close the chapter, but there are implications that we believe that go beyond, much more beyond pancreatitis. For this, I contacted my colleague, Dr. Marek Blahelovic, who's here in the audience. He's an expert in ultrasound imaging. And they were interested in studying myocardial function. And we said, well, we can try linoleic acid. Let's try injecting that. And it worked. If you look at, for example, here, this is the heart of a pig, which had been injected with linoleic acid, and it infarcts within 15 minutes. And the function of the left ventricle gets impeded, as you can see by this strange pattern that's graphed here. So injection of linoleic acid caused this. We went further, and this was a poster that he presented yesterday, where if we give intracoronary linoleic acid, there is a trend of reduced ejection fraction that we see by infusing that. So there seems to be a direct damage of linoleic acid to the heart with a drop in function and necrosis, which may be relevant to areas beyond pancreatitis. We see the same thing in COVID-19. So with my colleague, Dr. Rodrigo Gardenciba, who is an expert in critical care, that when we took COVID-19 patients admitted to the ICU and compared them to non-COVID patients who were admitted to the ICU, the only fatty acid that was statistically increased was linoleic acid in the COVID-19 group, and its metabolite, arachidonic acid. And yes, they had the cytokine storm, as you can see over here, compared to the non-COVID group. Yes, these patients had more organ failure. Yes, they required ECMO more. Yes, they had more thrombosis events that we see. Now, interestingly, they also had more hypocalcemia and hypoalbuminemia. And this is a large retrospective cohort of about 4,000 patients. And what you can see is this is broken into non-survivors, about 571, and 3,400 odd survivors. And these are the daily calcium and albumin values in these patients from the day of hospitalization. It's interesting to note that not a single albumin by the second day is above 4. in the non-survivors. This is very similar to what we see as a part of severe pancreatitis. In fact, Ranson's criteria and Glasgow criteria have these same things included in them. So could the pathophysiology be the same? And what we note is that yes, albumin and calcium bind linoleic acid very well. There's a very strong interaction, many times stronger than conventional protein-protein interactions. Experimentally, we have also seen that if we give linoleic acid to mice, there's a big release in DAMPs, vascular leak, organ failure, arrhythmias, thrombosis, and early calcium and albumin, early, not late, early calcium and albumin where we can pre-neutralize these fatty acids, outcomes get better. So, but why don't we do this? Why has linoleic acid become so bad? Why do we see these bad outcomes? Whereas it is thought to be a good essential fatty acid recommended by us in our diet. So what went wrong? Well, we are taught that linoleic acid is an essential fatty acid. It is good. But essential was always meant to be scarce and small. And as you will see in the next slide or two, it has become excessive. We are also taught to follow the calcium albumin correction calculator. And perhaps that it contributes to our lack of responsiveness to this drop in calcium, early drop in calcium and albumin that takes place in these sick patients, and we don't intervene. So let's look at the evidence. Yes, the FDA has recommended that unsaturated fatty acids should be the main part of our fat source. So this is, they say if you take 65% grams fat, 20 grams or less should be saturated. So yes, 70% should be unsaturated. That's been the recommendation. And if you trace this backwards, when did this happen? The red line you see here is soybean oil. And if you Google this, the largest consumed oil in the world now is soybean oil. Soybean oil was not big consumed till the mid-1950s, 1960s. And if you look at the composition of soybean oil, the blue line, is the biggest thing in soybean oil. And this is linoleic acid. And if we look at the consumption of soybean oil per capita, it is about 12 kilos per person per year is what we consume. And a study which took just the simple gas chromatography data from every paper published 1950 onwards shows that the composition of linoleic acid in our adipose tissues has gone up from that 5-10% range to 20 to 25% range, a 2 to 3-fold increase over the last 50 years. And that is what we are seeing, my friends, as what perhaps is causing the organ failure, the ECMO requirements, and the thrombosis, or the myocardial infarcts that we can perhaps induce, or the myocardial dysfunction that we can induce. In med school, we are also taught to go by the calcium albumin calculator. Basically add back 0.8 milligrams per deciliter of calcium for every gram drop in albumin. So this was, you can go to any calculator, an MD Calc. This is from up to date. So if you take a calcium of 9 in a normal person, albumin of 4, the corrected calcium is 9. Good. Now I get sick and I go to the hospital. My calcium drops to 7, albumin to 1.5. The corrected is still 9. You can do this on any calculator. I'm pretty sick now. I'm in the ICU. My calcium 6.2, albumin 0.5. My calcium will still be 9, corrected calcium. Nobody corrects at the early stage. It is only at this stage that we correct. And then I'm dead with a calcium of 5 and albumin of 0, and it's still 8.2. Now, where did this all come from? This came, the original paper, 1973, British Medical Journal, was interpretation of serum calcium in patients with abnormal serum proteins. And this was from a clinical laboratory. What they were trying to do was a normalization of their 2 peaks that they saw into one bell-shaped curve. And the only way they could do that was implying these calculations, because the specimens that they included were from wards, sick patients, and outpatient departments. So one had a cluster of normal calciums, the other had a cluster of low calciums. And what you see over here is that they had 2 peaks, which they could normalize with this calculation. But this was never meant to be implied clinically, never meant to be used clinically. In fact, the only corrections we do with calcium are once the patient's already in the ICU and pretty sick. You cannot bring dead cells back to life. The correction perhaps needs to be done early. So based on this, What I've learned over the last few years at Scottsdale is some mechanistic reasoning that perhaps what we've learned in pancreatitis may be relevant to other diseases, and that there may be some fundamental flaws in modern medicine that perhaps need to be reversed or prevented if we want to improve outcomes. Thank you.
Let's open to some questions. Dr. Whitcomb.
First of all, congratulations. This work is extremely important and very interesting. I was wondering if you could address the issue of fish oil and those saturated fatty acids that are recommended because they are actually anti-inflammatory and reduce cardiovascular risk, and in fact are recommended. And secondly, there have been, I believe, 2 studies that have shown that if you infuse the unsaturated fatty acids in patients with acute pancreatitis, it improves outcome. And the last correlate is that how important is the presence of pancreatic lipase to cause cardiovascular and other injury? Without the pancreatic lipase, are unsaturated fatty acids as toxic?
Great questions. So fish oil is not a fatty acid. Fish oil is a triglyceride. And the nature of double bonds in a fish oil make it more resistant to lipolysis. If you take the same fatty acids in fish oil in the hydrolyzed form, nobody's infused that. In fact, if you do a human clinical trial, you'll have to stop very early because it's the fatty acids that cause the damage, not the triglyceride. We store a lot of triglyceride. The fish oil is all triglyceride. So it is not the triglyceride, it's the fatty acid that causes the damage, and those are more resistant to lipolysis. That's one. The second about lipase. Lipase elevation, if you look at, I didn't have that slide here. There are about 20 different reports, whether it's critical care, whether it's myocardial infarction, stroke, wherever there has been lipase elevation documented in these studies, there have been a higher risk of bad outcomes. Obviously, lipase alone is not going to do anything. It needs a substrate. So that is just a risk factor that, okay, then the injury was severe enough to cause a lipase leak, but the substrate has to be there itself. And that's what we see, for example, in that slide where I showed bad outcomes at lower BMIs. It's the triglyceride substrate that has to be conducive to lipolysis with that causes bad outcomes.
So the dietary recommendations are to avoid saturated fatty acids, and because there are health benefits on one hand, and there's health risk on the other hand. And so the balance is actually a critical discussion.
Yes, absolutely.
Interest of time, one more question, brief question.
Jeez, I hope this is a good question. It's very quick. What happened when you're looking at, have you noted anything happening with starlet cells?
I'm sorry?
It's starlet, you know, the ones that are next to the ACE and are starlate cells?
Stellate cells.
Yeah. Well, it turns out vitamin A depletion, and they seem to be disrupted and they seem to leave. There's other types of nerve gas causes pancreatitis. It seems to disrupt that area. I was just wondering if what you're looking at is a disruption that's causing the acetylcholine receptors that are on ACE and are to be disrupted so that the starlets can't stay there to do whatever they do.
Yeah, we have not looked at stellate cells so far.
Stellates.
Yeah,
I'm sorry.
Though that's a great point you bring up. Perhaps there is some role of fat in stellate cells. We do note fibrosis to be a barrier between the adipose compartment and the exocrine compartment, which comes from stellate cells. But we have not explored the role of stellate cell physiology and its interaction with lipids so far.
Okay. Well, Dr. Singh, that was an elegant lecture. Please join me in thanking Dr. Singh. And on behalf of the on behalf of the APA this plaque to commemorate the Paul Webster Lectureship. Distinguished speaker to Dr. Singh. Congratulations.